Presentation today is on pandemic preparedness in the United States. Next slide, please. Next snap. Okay, so what is pandemic preparedness? It's basically a process in which planning and exercising take place on a national and subnational level to prepare and respond to threats that affect human health. And then healthcare delivery preparedness is when the hospitals, the healthcare systems, and their partners prepare to plan to respond and quickly recover from any threats to human health prior to it occurring in order to protect the national healthcare system and public health infrastructure.
Awesome. So I think it's important in order to describe the state of the pandemic preparedness that has characterized the US over the past year, we need to look back to see how we got here. Many regulations in place today stem from early 2000s regulations that were first implemented on a large scale through the H1N1 pandemic in 2009. And so in many ways, H1N1 was sort of a wake-up call for many people to learn some lessons from it, but also we see that there were some warnings that we could have heeded that were neglected. Next slide. So to start, I think we should clarify the difference in preparation involved for an influenza pandemic versus a pandemic from a novel virus such as the SARS-CoV-2 virus. The US had been preparing for years to combat an influenza pandemic, and it was because it's been known for so long that it's a threat. It continues to pop up on our radar every single winter. And so as such, an incredible amount of money and resources are already allocated to research and development for influenza-related medical countermeasures, treatments, therapeutics, antivirals, vaccines. And so when the H1N1 pandemic hit, the country had many of these necessary resources waiting, and or the research was there to start ramping up production of any sort of medical countermeasure or vaccine. But unfortunately, with COVID-19, we knew very little. So general funding for vaccines, therapeutics, diagnostics ends up in general to be reactive instead of proactive. So I found in my research, there was at least one instance of a coronavirus vaccine that was ready for human trials in the early 2010s or mid 2010s, but nobody would fund the project because, you know, interest had sort of waned after SARS and MERS never became global in nature. So attention was lost, and that left us in a compromised position. Next slide. We'll have a quick video just to describe the medical supply chain with H1N1.
Or no capability to respond to these types of events.
Greg Burrell ran the Strategic National Stockpile, the SNS, a series of government-run warehouses filled with medical supplies like ventilators and masks, which were critically important during the H1N1 pandemic.
The SNS response to H1N1 was the largest deployment of the stockpile. What was your focus during that time?
During H1N1, we sent out personal protective equipment that we had stocked for a pandemic influenza event ahead of a great deal of disease spread. So it was already in place. We showed we could get that material out rapidly and it could be made available.
The problem was H1N1 ended up depleting the stockpile. And in the ensuing years, neither Congress nor the White House moved to substantially refill it. One government report found that many of the N95 masks in the stockpile were past their expiration date, some broken, gathering dust and mold.
We bought the N95 masks that are in the stockpile with funds that were appropriated in the early 2000s. They've passed their expiry date, but we didn't have additional funds to buy more, so we made the difficult decision to hold on to those. You can't be prepared if you're not funded to be prepared.
Why do you think you didn't receive those appropriations?
You'd really have to ask the Congress.
Okay. So as you'll find as we continue on, health funding is a huge thing, and it specifically really hindered our ability to mobilize our supply chain, specifically within the context of COVID. You can go to the next slide. And then it's important also to talk about the public health workforce. I found a really interesting report from the Association of State and Territorial Health Officers that was like sort of a review of H1N1 and how prepared we were or not prepared for a public health emergency response. And as you can see, these are just some quotes from that report. They found that we didn't have a sufficient workforce and that we relied too heavily on volunteers. We had strained public health laboratory capacity. We didn't have the surge capacity necessary for anything that might have been even a little bit worse than H1N1. It was sort of a warning to the future for any other sort of pandemic responses. And generally, we didn't have the public health workforce necessary. You can go to the next slide. And this went into then our public health funding. You can see here that the CDC's budget for public health emergency preparedness dropped by half from 2002 to 2020. And then similarly for hospital preparedness, funding dropped 62% in just 16 years. Next slide. So this all sort of leads to a few key things of like weaknesses that were exposed from H1N1. So we had chronically underfunded public health services, strained and limited public health workforce, as well as primary care services. Supplies we knew in the strategic national stockpile were depleting. And the Crimson Contagion was something I also just really quickly wanted to bring up. It was a pandemic simulation that happened January through August of 2019. And in it, it was a ton of government entities working together to sort of solve a pandemic simulation. And we saw that there was not a clear outline of roles for specific departments, and that the domestic supply chain was weak, and international production would not have been able to meet US demand if there was a pandemic situation. Next slide. So this all brings us to the final slide for me to show the US's funding priorities for the Department of Health and Human Services. This was proposed in February of 2020, right before the pandemic really took hold. And it was supposed to enact for the fiscal year 2021. And you can see the budget was very focused on pandemic influenza, and that was a huge priority, while other departments had significant budget cuts. And of those groups included Project BioShield, which really helps to develop medical countermeasures for anthrax, bacterial resistance, and emerging infectious diseases. We also saw significant decreases in hospital preparedness and medical reserve corps.
Right, and as we move into our discussion about pandemic preparedness from the previous times, which Julia has brought up, to the times we're familiar with now in 2021, beginning in March 2020, we now can take a look at what the US has been doing for the past approximate 338 days ever since COVID was declared as a pandemic. How has the US healthcare delivery system fared? A simple answer, as we know and live it, is not so well. Firstly, we delve into the topic of medical research during the pandemic and how such challenges affect how it's conducted and carried out. The major goals of research being during this time to focus on the epidemiology of the virus as well as other additional factors. You take into mind the modes of transmission of the virus, clinical presentations on how to deal with the outbreak, figuring out preventative measures as well as how effective they are, as well as possible methods of treatment. March 2020 would require research to be time efficient and flexible. We look at the developments that have occurred during the start of the pandemic, reflecting a rather strong start in tackling medical research. The introduction of innovations that have advanced the overall understanding of clinical research to the urgency events is it's very evident. For example, for the National Institutes of Allergy and Infectious Diseases, or the NIAID, and the National Institutes of Health, the main priority to perform more clinical trials of antiviral treatments, and this requires a redirection of clinical research resources for a more rapid administrative response. And through their oversight, they would allow for different innovations, including remote visits via telehealth, home-based testing, monitoring technologies, and enforcing the requirement of safety precautions in establishments, for example, wearing masks and placing importance on social distancing. So there would be some examples of strengths offered during this development. And clearly, as we progress, there's also importance placed on the development and production of the Moderna and the BioNTech vaccines, et cetera, approved as soon as December 20 for emergency use. However, when we consider the weaknesses, they greatly overshadow the strengths as even more challenges pose themselves while conducting research during this pandemic. It's challenging as there is many factors, including patient hesitancy, the inability to continue investigative treatments due to self-isolation and quarantine, limited access to public places, including hospitals, and the interruption of supply chains and monitoring of clinical trials. These culmination of additional obstacles show how many weaknesses there are that pale in comparison to the strengths. In addition, the failure to implement appropriate solutions in a timely manner is a critical issue that prevents the US from preventing the onslaught ever since the rise of the pandemic. Effective preventive measures such as the vaccinations or therapies are just simply unavailable, as witnessed with previous pandemic infectious diseases, as touched upon by Julia before. Even when there are resources and funding allocated for research, the lack of continuation of funding once the outbreaks are over only leads to the disruption of many clinical trials assessing preventative, diagnostic, and therapeutic strategies. Next, we continue on to the relating the pandemic and its effect on supply chain. And the pandemic has really already exposed the vulnerabilities of many organizations, especially those who have such a high dependence on China to fulfill their need for the raw materials or finished products. China's dominant role as the world's factory means that any major disruption puts global supply chains at risk. Highlighting this, where there are 200 out of 500 major firms of Fortune Global that have a presence in Wuhan, the highly industrialized province where we know the outbreak originated. Those have been the hardest hit. And companies whose supply chain is reliant on direct and secondary suppliers are likely to experience significant disruption, even if more optimistic resources and conditions want to approach normalcy. And it's most evident, mentioned before, with a big focus in the hard-hitting impacts on supply chain prevalent in the vulnerabilities in production with the pharmaceutical firms and critical medical supplies, as there's a rapidly growing imbalance between supply and demand. In turn, this creates the dilemma of how resources can be fairly allocated to the population. And delving into numbers for quick detail, there are approximately 62,000 full-featured ventilators available in the US, which adequately treat the most severe complications of the virus. Another 10,000 to 20,000 more are estimated to be on call, and 98,000 basic ventilators that are not full-featured but can provide basic function, as demonstrated with the figure on the left. And taking into mind that we live in the pandemic, however, on top of further limitations on the rapid production of more ventilators, the prime limiting function for use is also not having enough people to handle them well. Considering this and the epidemic curve, the COVID-19 pandemic has already caused a shortage of hospital beds, ICU beds, and ventilators, and also affects the availability of the medical workforce. Furthermore, diagnostic, therapeutic, and preventive interventions are scarce. Even though there has been testing before, ever since the start, with pharmaceuticals such as chloroquine being tested, even if such substances were to be useful, scaling up supply would take time, not to mention how much time it would also take to produce, distribute, and develop a vaccine. And of course, while that's been accomplished now, again, take into consideration the amount of time it took. And finally, for my last slide, we examine COVID-19's impact on the workforce. And this is one of the more clear signs which even the most prepared people could not have withstood it. It's absolutely decimated the workforce. With the chart seen, unemployment rate has shot up in the early months of the COVID-19 crisis. And while employment has increased every month since then, the 14.7% peak in April shows how decimating it was in the beginning. Furthermore, payroll employment numbers show that 20 million jobs were lost in April, and youngest workers saw the biggest decline in employment, especially prevalent in the leisure and hospitality sector, losing the most jobs. And of course, lower earning occupations were hit the hardest. Also, in relation to the workforce, it's also very noteworthy to mention that there are long-lasting psychological impacts on all members involved directly and indirectly, observed clearly with healthcare and frontline workers, essential workers, students and educators, and other populations most predisposed to risk and vulnerabilities. Organizational and employment aspects have a considerable impact on psychological health, especially in the context of the pandemic, and mental issues related to the health emergency, such as anxiety, depression, PTSD, etc., are more likely to affect these workers. And for these reasons, the public health response must address this issue of this psychological pandemic. Furthermore, as we offer this presentation today, we offer a clear change that has impacted the very way we communicate ideas. And this is known as like the new normal of working from home and communicating through technologies more so than ever before, which has clearly impacted the workforce. And again, there may be potential advantages with keeping with this, as having the flexibility to work from home is a great option for all workers, especially for those with disabilities. But once again, we must consider the psychological impacts as stated before.
The CDC provided a critical infrastructure for COVID-19 response in an attempt to enforce specific guidelines to prevent the spread of the virus. Some of the guidelines were met with resistance due to the current status of the economy and became more of suggestions to be followed. Business and employers, including healthcare, are implemented to do daily health checks, maintain social distancing, and act if an employee is suspected or confirmed to have COVID-19. In education, consistent use of masks by all at all times, maintain a safe distance of 6 feet. Teachers are to teach and reinforce consistent hand washing and frequently cleaning and disinfecting all areas. The others, they are also required to follow protocol for contact tracing of infected individuals to be reported to the health department. Community events pose higher risk of spreading COVID. The guidelines suggest virtual only activities, events, and gatherings. In-person gatherings require wearing masks, especially when moving within the crowd, demonstrating hand hygiene and respiratory etiquette, and keeping contact under 15 minutes. Slide. Healthcare providers in the US have been inching towards making services available via telehealth for years. With the pandemic, telemedicine has accelerated by a decade, allowing for remote consultations and monitoring by healthcare professionals. It also gave the government the opportunity to institutionalize systems to work together at all levels in healthcare to move towards a new reality of post-COVID. Slide. Regulatory mechanisms for COVID allow for new era of healthcare preparedness by realigning healthcare systems to prevent and treat chronic disease, which represents more than 80 cents out of every dollar spent on healthcare. Solving data dilemma to allow for shared information across systems, training our physician workforce for the challenges of the 21st century and not the 20th century. It is important to eliminate paperwork, the needless paperwork and regulatory burdens that are obstacles to efficiently deliver a high quality care for individuals. It is suggested that our healthcare professionals' roles in care should be at a 70% of primary care handled by advanced practice nurses to reduce the cost of services. Racial disparities are currently needed with the purpose to root out racism inside the healthcare system and identify and eliminate systematic inequities that are responsible for poorer health outcomes for Black and Brown communities. Slide. With drug affordability, the NIH has been tasked to re-examine the mandate of licenses potential drug candidates to make drugs available on reasonable terms and not to interpret it reasonableness, allowing for the government to exercise negotiating power. Drug manufacturing should be now manufactured in the US after China entered a national lockdown, causing shortages of the medical supplies in North America. And the FDA has expedited development and regulatory review of new vaccines due to the high priority and accepting greater uncertainty for flexibility and evidence that is required for approval. Slide. The COVID funding implemented a recovery and economic relief option that would, one, allow affordableness, accessible testing and treatment, two, support frontline healthcare workers, three, improve the public health infrastructure, four, provide protections for vulnerable groups, and five, to allocate funds for vaccines, treatments, and research. Slide. On October 1st of 2020, roughly 2.9 trillion in a new budget was approved to roll out in phases. Legislation mandated for the government to defer and reduce taxes to provide relief to individuals and businesses. This estimated to a 3.49 trillion with an estimated 2-year impact of over 902 billion in tax relief. The plan also contributes to funding for credit, loans, and loan guarantee programs, which estimate a total of 3.9 trillion in total lending. And the CARES Act was also implemented for other supplemental resources to the pandemic. Slide.
So with all that being said, we kind of asked ourselves, a year into the pandemic, has the United States made progress towards solving its healthcare deliveries problems? Slide. And with a new administration change comes new implications for COVID-19, and this involves a national strategy for the COVID-19 response and pandemic preparedness that was imposed by President Biden. And this is composed of 7 main goals, which include to restore the trust within the American people, mount a safe and effective comprehensive vaccination campaign, mitigate spread through expanding testing, data treatment, and masking, and 4, to expand emergency relief and increase budget for the DPA, safely reopen schools, businesses, and protect workers and travel, protect those at most risk and in ethnic and rural urban areas, and also expand into other areas such as brown and Black communities, and to restore the US leadership globally and to build better preparedness for future threats, which we should have been doing.